So my name is Nick Feiner, and it's my pleasure and privilege to be moderating this session. I'm an adult endocrinologist by training, and all things being equal, tomorrow I shall be taking over from Tony Holland as president of IPSWO. So I look forward to the next few years. So it's a great pleasure to introduce this session on aging, cognitive, physical and social health. And we're really very privileged to have Laura de Graaff come and speak to us. She's an adult endocrinologist, associate professor of genetic and developmental endocrinology at Erasmus and Radboud University Medical Center in the Netherlands, and the founder for the Center for Adults with Rare Genetic Syndromes. She has a very large clinical practice caring for over 1,300 people with rare genetic syndromes. And there's nobody better really to give us this talk on aging in Prader-Willi syndrome. So Laura, thank you very much.
So hello everybody, and I'm very happy to be here. Thank you for this kind introduction. So I'm working actually in 2 hospitals in the Netherlands because I first set up a clinic for patients with rare genetic syndromes in Rotterdam, which is in one part of the country. And then an academic hospital at the other side also wanted to start a clinic, so I'm now working in both hospitals to set it up there as well. So that's why I have all those different affiliations here. These are my disclosures. And this is the group that we're really talking about. So I don't only see people with Prader-Willi syndrome, although it's the largest group, but I also see people with different syndromes. So in this slide, you see a person with Williams-Börle syndrome. It's a very interesting syndrome as well because the people have extreme musical skills. So they are extremely talented for several music instruments, singing, and they of course also have medical problems. That's why I'm there for. Then you see people with neurofibromatosis, Down syndrome, as you can see. Below is somebody with Charge syndrome. We see left below Silver-Russell syndrome. Then at 9 o'clock, Klinefelter syndrome. 11 o'clock, Turner syndrome. So we see all kinds of syndromes. People with all kinds of syndromes. And as for Prader-Willi syndrome, the same is true for all these syndromes. So life expectancy used to be much lower than it is now. And thanks to excellent pediatric care, they become older and older, which is great. But they had to leave the pediatrician because they became too old for the pediatrician. Pediatricians are not trained to treat adult patients. So that's why the pediatricians asked me to set up a clinic for the adults, and that's what I did. So here are the adult people that you see with the same syndromes, and the complexity of the syndrome really does not change when people become adult. So let's say the definition of a syndrome is usually it's a combination of a brain problem, can be intellectual disability or autism or epilepsy. And it's always combined with physical problems like heart problems, hormone deficiencies, organ problems. And usually people also look different. So that's more or less the syndrome definition. And the same combination of problems persists into adulthood. So that's why I thought it was strange that there was no adult clinic yet. And that's why I started it. So these are the people I work with. On the left you see my team of 3 medical doctors and a nurse practitioner. The nurse practitioner, she's really, well, we couldn't, if she would not be there, everything would fall apart. She coordinates the clinic. She is the primary contact person for all the patients. And she does her own outpatient clinic as well. Then on the right you see some people with PWS. We see young people, we see old people. The oldest person with PWS that we saw was 72. And then below you see somebody who has a combination of two syndromes. So that's Klinefelter syndrome and Prader-Willi syndrome. And both syndromes affect muscle strength. So he was severely affected, but thanks to the treatments that we gave him, he was more and more mobile. I will tell you a bit more about that later. This is the multidisciplinary team. I think because the syndromes are so complex, it's very important to have a multidisciplinary team, because people not only have one problem, but they have several issues at the same time, usually. So I'm very happy that we have a neuropsychologist, which is here in the room as well. Hi, Anja. I think the neuropsychologist is very important because she can assess the real developmental age of the person with the syndrome. So that's really important for caregivers to approach the person at the right level, because we see in many syndromes that people can talk quite well, so they seem quite, they seem, let's say, more intelligent than they really understand, and that what causes overestimations most of the time. So they can get really stressed because they are overestimated, and that's why I think the neuropsychologist is really important, because we can prevent a lot of problems by preventing that overestimation. Then we have also two physicians for intellectual disabilities. That's a specialism, a medical specialism that is new. In the Netherlands we have it since 20 years, but in many other countries it doesn't exist yet. So it's a specialized doctor for all the problems that are associated with having intellectual disabilities. So also legal issues, other complex issues about living with intellectual disability. So they are very important as well. We also have clinical geneticists, we have a geriatrician, and a specialized dietitian for intellectual disabilities. In the Netherlands, we have a specialized program, diet for people with PWS, which maybe you might have heard of, which is the DOT diet. It's a very nice way to keep the autonomy while keeping a very healthy diet, so people can choose themselves what they're going to eat during the day. And thanks to the colored dot that it has, they can count dots and make their own menu, and it really works very well. So I think for Prader-Willi syndrome, I can illustrate the added value of this multidisciplinary team. So the 4 squares really represent the problems that we see in people with PWS. So I'm the endocrinologist of the team, so I focus on hormone problems. People with PWS can have several hormone deficiencies. So the thyroid hormone can cause them to be really tired, to gain weight, to become like lazy, whereas they didn't used to be lazy. So we had many people with undetected thyroid hormone problems who were very inactive. And that was not because of a behavioral issue, but they just had too little thyroid hormone. So my task is to detect these hormone deficiencies and to treat them. So thyroid hormone is one of the hormones that can be real problematic. We also see a lot of people who have a lack of testosterone or estrogens. Those are the sex hormones. So those are the hormones that change boys and girls into women and men. And in, let's say, 99% of all the people with PWS, they are lacking. So these hormones are very important for body composition, so to stay healthy, to have healthy bones and to prevent fractures from happening. The problem with those hormones is that the treatment of sex hormone deficiencies can cause interaction with anti-epileptic drugs, and it can also cause behavioral issues if you don't dose it well. So we have had several patients in our outpatient clinic who were not using those sex hormones because the parents and the caregivers were afraid of causing behavioral issues. But we know that if you start it at a really low dose and you increase it very slowly, there are no behavioral issues. So I think there's a lot of undertreatment at the moment because people are just scared to start this treatment. But if you start it really slow and increase slowly, you can easily treat them without any problems, and it's much better for their physical health. And you prevent a lot of problems in the future. So it's good for you to be aware of that almost everybody with PWS has these hormone deficiencies. So if your child or the person you're here for is not treated yet, please discuss it with the pediatrician. So that's my part of the multidisciplinary approach. Then the dietitian is very important. Not only because of the hyperphagia, but also because of the low rest metabolism in PWS. So we know that people with PWS have low muscle mass. They are born, as you know, like floppy infants, so the muscles are really weak. But that also causes them to burn less calories. So if you give them a normal diet, which would make a non-PWS person lose weight, they will still gain weight because their metabolism is different. So it's very important that when you go to a dietitian, you see a dietitian who has some knowledge about PWS, and that calorie intake should be like 65% of what would be normal for a non-PWS person. So I'm very happy to have this collaboration with the dietitians. Then right lower angle, the neuropsychologist that I already talked about, very important to prevent overestimation and also to make the way that the caregivers, also in a group home, manage the people with PWS is the right one. Because if you don't do it in the right way, they can easily get behavioral issues. They won't want to practice or exercise anymore, and then it's not good for the physical health either. So all these different parts of this multidisciplinary approach they really have the aim to prevent, in the end, the physical problems, to prevent obesity and the complications of obesity. Now, it's also important to have a physiotherapist involved. We see a lot of adults with scoliosis, with hypotonia, so this low muscle mass. And it's very important to have the physiotherapist involved to tackle those problems of the musculoskeletal system, to keep them mobile and to keep them moving. So that's what we do to prevent obesity and the complications. And I think in 90% of our patient population, it works really well. Now, this is a slide you don't have to look into detail to, but it's just about something that I wanted to tell you. It also is true for many countries in the world that there is no adult syndrome care yet. And that is because many adult endocrinologists, many adult healthcare professionals in the hospital are a bit scared of starting an outpatient clinic because they think the syndrome is so complex, because they think they don't know what to do, because they have many reasons not to do it. But it's very important that they start doing it. So what I did in the Netherlands, I made overviews for all the syndromes that I saw, like 130 syndromes up to now, made overviews of everything that my colleagues should look at. So for PWS, as I said, be aware of thyroid hormone problems, be aware of bone quality. And I did that for all the syndromes, and that really helps the adult endocrinologist in my country and also in other countries to start similar outpatient clinics. And that way, many more patients can be helped. So I've been talking to many people here. I noticed that in many countries there is no adult follow-up yet, and people are really worried about what's going to happen to my child when they turn 18. Maybe it's good to scan the QR codes so that if you see an adult healthcare provider and they don't know what to do, that they can look at those articles or they can contact me if they have questions. I think it's really important to start educating the world, the adult healthcare providers, to take care of people with genetic syndromes. And most of the things we made are really easy to read. They are with visuals, so it will really help them. And I'm very happy that in my country, I've managed to convince now a group of 12 adult endocrinologists who are now also seeing people with rare genetic syndromes, also people with Prader-Willi syndrome. So we're making a network of syndrome doctors. It's just, we have to take their fear away and then they will start doing that. So now, that was a part of transition. So what do we do when the children have to leave the pediatrician and have to make the transfer to adult care? But then this talk is about aging. What we see in people with PWS is that they seem to age prematurely. So what I see in my patients, we see over 200 adults with PWS, is that from the age of 30, they start looking older. Not only having wrinkles and gray hair, but also their back becomes more curved, they become weaker, the muscle mass goes down, which is normal for older people like 70 or 80, but in the PWS people it happens much earlier. And the very important thing is that doesn't happen in the ones who are using growth hormone. So we have half of our population who is without growth hormone because they are really older and they were young. The growth hormone didn't exist yet as a drug. So in those people who have never been on growth hormone, we see this premature aging. And in the ones who use growth hormone since early childhood, this premature aging is much less. So that's good news. The things we see that happen in PWS, they have some overlap with the normal, I don't mean normal, but the non-PWS aging population. So muscle mass goes down, they get more abdominal fat, they get less mobile, their cognition so the brain function can become less. So there are all kinds of things that happen, and we don't know the real cause of that. So we're now looking into the causes of this premature aging. They sometimes have cognitive deterioration or impaired brain function earlier than we would expect based on their chronological age. And there has been some research about brain imaging in people with PWS. It's a very technical article, so I will tell the headlines, let's say. So you really see that the people with PWS show a brain age which is like 8 or 10 years older than their calendar age. So the brain is showing accelerated aging. And it's important to know because in the people who are aging prematurely, when they are still 30, they sometimes need the facilities and the support material of somebody that is 70. And it's very important to be aware of that. This is a bit of a small screen, so I will look that way. Yes, we see a lot of age-related disorders already at young age. So you know that disorders like diabetes, hypertension, and lipid problems, so high cholesterol, usually occur in people from 50 years and older. I'm turning 50 this year, so this is a delicate question. But officially, the risk of diabetes, hypertension, and dyslipidemia, so high cholesterol, is really going up after the age of 50. But in people with PWS, we see this earlier. And I think there I want to say something about the Informed PWS network, because that's a large network of adult endocrinologists all over the world who are, well, you see the slides, probably you will know some of them, adult endocrinologists from different countries. And we have joined forces to investigate the problems that we are seeing in a large group of adults with PWS. So together we are investigating 800 adults with PWS, which is really the number you need to draw firm conclusions about the medical aspects of the syndrome. Together we do a lot of research. We have made, this research has resulted in 2 doctoral theses, so PhD trajectories, and they are all about improving medical care for PWS adults and improving medical care for people with rare genetic syndromes. Those articles that we make and the manuscript that we publish are all meant to be recommendations for other adult endocrinologists and other adult healthcare providers all over the world. And one of the articles that we made together is about the healthcare problems that we see in adults with PWS. It's like an overview of all the healthcare problems that we see and also the healthcare problems that are missed when you don't look for them. Many people say, well, my child is or my adult child, he's living a good life, he's healthy, I don't notice anything. But the problem is sometimes you don't notice that a health problem is going on until it's too late. So it's important to screen, to search for health problems so that you can treat them early and then you prevent them from getting worse. So that's what we also did in this project. We screened a large group of people with PWS and we looked which healthcare problems were there that had not been detected yet. So we made an overview of all the health problems that we saw per age category. And we saw that in the young people, up to 25, there were not so many problems, especially in those with growth hormone treatment, there were not so many physical problems. Then in the group of 25 to 30, it started coming. But then in the group age over 30, all of a sudden there was much more diabetes, much more hypertension, much more cholesterol problems. And those are the diseases or the disorders that you usually see when people are really older. So it's important to be aware of that if your child is 30 years old or older, please have them screened every year because you don't notice that they have these issues and it can really impair their future because in the future they will develop the complaints that go with these problems. Then a lot of people who are becoming older with PWS, they have reduced mobility. So we see many people with PWS who are like 50 years, 55 or 60, and they really get less mobile. So they don't want to go on day trips anymore. They just sit in the chair. They don't have the energy to move. And sometimes they have other like muscle issues or joint problems that make them less mobile. And I think that's very important because mobility is very important to keep them healthy. And here I want to tell you about the vicious circle of Prader-Willi syndrome that we see. As you know, they are born with less muscle and more fat. That's just part of the syndrome. And because of this low muscle mass, sometimes they have what we call exercise intolerance. So exercising is hard for them. They have less muscle strength, so they cannot keep up with their peers. They are sometimes less good at sports. And that also causes them to sometimes not be so willing to exercise. And if they start exercising less, the muscle mass goes even down, they get more fat, and there's where you enter this vicious circle. And in the end, this vicious circle leads to obesity and complications, because if you don't exercise, especially knowing that we have this low rest metabolism in PWS, you really have to exercise. If you don't do it, you enter this vicious circle, and that leads to obesity and the complications. So what we want to do, what we do in Rotterdam, is we try to change this vicious circle into a positive one. And that sounds like a fairy tale, but I think with very practical measures we can really do that. So this is our standard approach to improve health in PWS. And I will tell you how we do that. We have a specialized program, combined lifestyle interventions for people with obesity. And a combined lifestyle intervention is psychological support, physiotherapy, and nutrition. So usually there's a lifestyle coach who works with the PWS adults to tackle those 3 issues. So mental support to start exercising, taking away the behavioral issues where possible, looking at nutrition and start exercising. Many of the times we do that together with a specialized company in the Netherlands, which is active all over the Netherlands. And they have a personal trainer for the people with PWS to train together. Of course, the most important thing in PWS is food security. So in the Netherlands, many people with PWS don't live with their parents, but they live in residencies. And many of those places are not aware of the way you should handle people with PWS. So the food is not locked. They can just get food anywhere, which causes not only a lot of stress, but also a lot of overweight. So we talk with the healthcare institute or the residencies to say, get the food locked, have a key on the fridge, etc., or a lock on the fridge. So once we have tackled all those basics of food security, lifestyle, then the healthcare insurance companies, they reimburse the GLP-1 medication that you might have known of. It's Wegovy or Ozempic, Saxenda. And those are the drugs that really help people with obesity to lose weight. When you have not done this lifestyle intervention for 1 year, it's not paid for by the healthcare insurance company, so sometimes parents pay it by themselves. So when we start those anti-obesity drugs, we can get the people with PWS to lose weight. And when they lose so much weight that their BMI is below 40, which is quite an effort, they can start growth hormone treatment. So I think most of the children here already use growth hormone, but for adults in many countries it's not reimbursed, and it's very expensive, so many adults with PWS don't use it. And I've been lobbying in the Netherlands to get the healthcare insurance companies to reimburse this growth hormone, and now since 2 years it is free for people with Prader-Willi syndrome in adult age. So when their BMI is below 40, we can start this growth hormone treatment, and that's, I think, where the happy story starts, because then you see that the muscle mass goes up, because that's the effect of growth hormone. And when their muscle mass goes up, it's easier to keep a healthy weight, and they also become much more active because they get more energy. So it's really, the people themselves are really enthusiastic about this growth hormone treatment. We don't always understand why this growth hormone works so well, and we don't understand why this premature aging that I was talking about is not happening in the people who are using growth hormone. So together with the geriatric department, it's the elderly department, we are looking at this aging process in people with PWS. And we are looking at aging in the clinical setting. So what do we see? What do we see in the patient with PWS? Is it that the hair turns gray? Is it that they get heart problems? Is it that they get hypertension, high blood pressure, etc.? All those age-related problems. We score that, we call it the geriatric score. And then we look in the blood, in the cells. Alvaro Carrasco Garcia was here yesterday. He got a Young Investigator Award for the research that he is doing. And he looks in the cells of the body to see whether the cells are aging prematurely. And that is a way to try to understand why people with PWS are becoming older after their 30s. So this relating the physical aging characteristics to the cellular aging features, I think is really a way to understand what is really happening in the body, and also a way to understand why it doesn't happen in people on growth hormone treatment. So for that we have a close collaboration with the University of Valencia in Spain. They are really experts in the field of cellular aging. And here you see Alvaro with his Young Investigator Award yesterday. Well, in this study that we're doing a lot of measurements to look at is aging, not only at aging, but also at the general health. So in total, we have 450 people with PWS in our center, 200 adults and the rest are children. We include them in the study if they want, of course, only if they are willing to use growth hormone. When they want to use growth hormone, we first have to exclude many, what's called contraindications. So there are always reasons not to give growth hormone. For example, if you have sleep apnea, if you have poorly controlled diabetes, if you have cancer somewhere, then you cannot give growth hormone because it makes the cancer worse. So we screen the patients for all those contraindications. And if they have the green light to start growth hormone, then we include them in the study. This is quite a big procedure, it takes a lot of time. So until now we have been able to include 25 patients. The Foundation for Prader-Willi Research is supporting this study, so I'm very grateful for that. And since we got the support, we have been able to include 25 patients. So this is what the study looks like. We check them every 3 months after starting growth hormone. We look at their bone density, we look at their muscle mass, we look at the fat mass, we do muscle strength measurements. So it's like a general checkup every 3 months to look at the effects of the growth hormone treatment. One of the things we do is the muscle measurement, and that's the fun part. The people who are participating really love this part. The first way to test the muscle mass is the 30-second sit-to-stand test. So they sit on a chair and they have to get up and sit down and get up and sit down and get up and sit down 30 seconds. And the more strength they have, the faster they can do that. And what they think is the nicest part of it is that I do it first to show them how they should do it. So it's very funny to see the doctor exercise. And then they do it after me. So the first test is 30 seconds, sit to stand, and then the second test is sit to stand 5 times and see how fast they can do it. And then there's an additional test, that is the hand grip strength, with the thing you see on the right, that's the hand grip dynamometer. They have to grab this dynamometer and push as hard as they can, and it really measures their hand strength. And the hand strength is a way to test the general strength of the body. So there's a good relation between the hand strength and the strength of the rest of the muscles in the body. Now, there are some practical issues with this sit-to-stand test because, of course, I can show them sit, stand, and I can show them how I do it, but usually after 2 or 3 times, they get distracted and they talk about the holiday that's coming or about their favorite pet or about the new clothes that they have bought. So they forget to focus on their task. So sometimes the measurement is not as good as it would be when they would be really focused. A lot of the times they also talk about what was the food yesterday, what's going to be the food tonight. Of course, that's very interesting, so I also want to keep up that conversation, and that's why it sometimes takes some time to really get the test done. Luckily, we have an hour for every patient, so we can repeat it until they stop being distracted. Now, what you see in this 30-second sit-to-stand test, here you see a graph with on the vertical axis the times that they can sit to stand. So the higher the better, because the green arrow is where they can really do it faster, and the red arrow is where they are slower. And on the left of the graph, there's the situation without growth hormone, and on the right, you can see it after 6 months of growth hormone treatment. Usually, the start of growth hormone, it takes 6 months to really see the effect. And that's what we see happening here. So some people really have a huge increase in muscle strength. Okay, so this is the 5 times sit-to-stand test. So here is the opposite. The lower the better, because the lower is, well, it means you do it faster. And you see this improvement in speed of standing, sitting, standing, sitting. Of course, those are important things for me as a doctor because I see that the muscles are responding and that the body is responding to the growth hormone treatment. But the most important thing is what the parents and the patients tell me. So they are really super enthusiastic about this treatment, not only because it makes them lose weight, but also because they get more mobile. So we had one person, a story of a man of 45 who was not able anymore to climb the stairs because he was getting older and could not walk the stairs anymore because of muscle weakness. And after 6 months of growth hormone, he was able to climb the stairs again. And he could not only climb 1 stairs, but 3 stairs in a row. So they were really amazed by the effect. Then another story was of a person who, with PWS who was very sedentary. So he was sitting in the chair the entire day because he was too tired or too weak to get up. And he could only get up with support of the caregiver. But after 6 months of growth hormone, he could really stand up of his chair by himself to go to the living room or to do something that he felt like. Of course, it also gave a practical problem because he could also walk to the kitchen. So they had to put a lock on the kitchen. But it was really showing the effects of the growth hormone treatment. And another third story was about somebody who could not, the parents had a duo bike, so a bicycle for 2 people. But because of the premature aging, this person could not bicycle anymore. And after 6 months of growth hormone treatment, they could go out for cycle tours again. And he was also able to go for long walks again. So the people really noticed the improvement. And the nice thing is they can also go on day trips again. So as I said, most people don't live with their parents, but they live in residencies. So they sometimes go out with the bus to the zoo or somewhere else. And many of the times, the older PWS adults didn't have the energy anymore to go on those day trips. But with growth hormone treatment, they really became more active. So what I see in PWS adults receiving growth hormone is improved body composition, so more muscle, less fat. More muscle makes them burn more calories, which makes it easier to maintain a healthy weight. And we are now looking at the cells on the blood results of Alvaro to see if we also see that the cells are becoming younger. And the first results are really promising. We showed that the old cells are being cleaned up and the good cells are kept in the body. So it seems like the body is really renewing, and that's something we are very happy about. Of course, those are preliminary results, but it's very promising. So I think there's a very clear clinical impression of premature aging in PWS. We see this reduced mobility, so they are not so mobile anymore. The brain becomes older. Sometimes they get gray hair. And what really are objective data, so things we can measure, is that there are age-related disorders like diabetes, hypertension, cholesterol problems, starting at a very much earlier age, from the age of 30 more or less. And another study of Stephanie Donze in the Netherlands, who's a clinical geneticist, but other groups are studying that as well, is that the chromosomes of people with PWS, so the DNA, is becoming old earlier than in people without PWS, which is also a very important thing to know. Then after 6 months of growth hormone, we see a positive effect on the leg strength. And more importantly, the caregivers report that they have more energy and improved mobility. And we are looking at the cellular processes. So what I want to tell you as well is, now that people with PWS are reaching old age, we notice that a lot of caregivers can really get exhausted because it has been so long that they've been taking care of the people with PWS. So we noticed in our clinic that many caregivers had caregiver burnout. So they were really having a hard time to keep vitality for themselves and to take care of themselves. Now in my hospital, I have set up a program for doctors to prevent burnout. because there were a lot of doctors who had burnout complaints. And that program was running in my hospital, so the doctors and nurses were taking part in that program to keep them vital. But when I heard all those stories of the parents, I thought, well, the parents are the real healthcare professionals. I should make this program for the parents of the people that I treat. So together with a large group of parents, we changed this support program into a parent support program. It's supported by an app. It's a real life combined with app intervention. And with a group of parents, we made the tasks that you do in this intervention, in this program, we made it fit the way that you live with a child with PWS or a child with another syndrome with intellectual disabilities. So it's really a parent support program, app-based program for parents of children with chronic disorders. It's now only active in the Netherlands, but we are working together with different countries to also translate it. So if you're active or if you're interested, please let me know and we can see if we can make it available for your country as well. I'm very happy that we have very good relationship with the PWS society in the Netherlands. So we have a lot of interaction, we have a lot of communication about what they think is necessary, and they also support our research. And we also go to, for example, radio programs together, because I think in the Netherlands, and must be in several countries as well, there's a lack of knowledge about the problems that people with intellectual disabilities have when they go, for example, to the hospital. So I have like a lobby going on to keep other hospitals aware of the fact that they should take extra measures for people with intellectual disabilities. And I do that together with Elise Zegwaard, who is part of the Parent Society, of the PWS Parent Society in the Netherlands. And by doing this together, people really listen to us. So that's, I think, the good thing about collaboration between healthcare providers and the parents. So that was what I wanted to tell you. Again, this is my team, without whom it would not be possible. So if you have questions, please send an email to prader-willi@erasmusmc.nl. These are the people that I work with. I want to thank them all. You don't know them, but I want to thank them all. And if you want to follow what we're doing, we are quite active on LinkedIn. You can see all the activities around people with rare genetic syndromes. So I'll leave the QR codes so that you can scan them. Thank you for listening.
Thank you so much for all that talk, Laura. That was fantastic. Well, we have plenty of time for questions. I think there are probably some people with roving microphones. So are there? Or shall we get... what's the best way of doing this then?
Shall I run?
No, you're the important one.
Are they on?
Yes. Well, thank you for the helpers with the microphones. I think you've got the microphone first, so...
Yeah. Okay, thank you so much. I have a question about menopause. And if there have been any studies or research done for our female daughters with Prader-Willi?
That's a very good question. The interesting thing is that 99% of the women that we see don't have spontaneous puberty because their hormone system is not working properly. So they get their periods because we are giving them the pills to give them the period. So there is no menopause because they don't have an active hormone system. So we give them the sex hormones like estrogens, in the form of oral contraceptives or other medication. So when we stop that, that's when they have menopause. Usually we stop it around the age of 50, because that's when menopause happens in non-PWS women, more or less. But there is no real menopause because there is no activity in most patients of this gonadal axis, as we call it. So the hormones themselves are not active. So we produce the first and the last menstruation, to say so.
So my daughter has been on reproductive hormones she's 30, so she's been on them since she was 16, 17. So I'm just curious as to, so what you're saying is that to remain on those hormones and then cease at 50 as she might do naturally.
Yes, so we usually keep them on the medication until 50, 52, and then stop it. And the very important thing when the hormones are stopped is that if your daughter or if women use anti-epileptic drugs or psychotropic drugs, stopping the hormones can really change the levels of those medication in the blood. So the doctor should really be aware that the medication activity and the effect of the medication can change when they stop the oral contraceptives. So it's good to be aware of that.
Thank you.
Can I just add to that, perhaps to ask, what about hormone replacement therapy? And do people with Prader-Willi syndrome, when you stop the estrogen, do they get hot flushes or not because of the lack of gonadotrophins?
They don't get hot flashes. So, and your question about hormone replacement therapy, there are two ways that you can give hormones. The high level is to prevent pregnancy, that's the oral contraceptives, and the low level is HRT, as we call it. That's to keep the bones healthy. I always prefer to give the low dose because people with PWS have more possibility of getting thrombosis, and high-level estrogens have a higher risk of producing thrombosis. So if you have the choice, choose for low-level estrogens, low dose, because it's good enough for the body and it takes away the risk of thrombosis for a large part.
Thank you. There's a question back there. Yeah.
I'm the parent of a boy, so this isn't regarding me, but over the years, probably over the last, I'm going to say 10 to 12 years, I have heard from many parents of young women, especially as their ages in, I'm going to say late 30s to mid 40s, who are going through extreme behavior changes, similar to what many of us went through when we were going through menopause. And it seems anecdotally like they do experience some sort of change in their body. And I did a search as well to see if there's anything out there, because I tend to I'm a retired nurse, and I'm very interested in the topic of aging. So I do hear from people sometimes all over the country. And to me, it seems like an area that needs more research, and that there may be some subtle changes that are going on that, you know, to the normal population, we wouldn't even notice. But as we are learning with people with Prader-Willi, that they are more sensitive than you and I are. So to me, it's an area that I hope we take a closer look at, because many of these women are being kind of poo-pooed. It can't be that. And they're left to suffer. Some of them are either going on or being taken off of hormone therapy, or their dosages are changed because of these extreme behavior changes. Many of them, like around the age of 45, seem to be coming out of it.
Yeah,
so
I think it's a very good remark. And what I wanted to say is what we see is that the hormone axis, so the hormones, seem to respond a lot to weight loss. And what we see in the people with PWS who are getting older is that many times the hyperphagia, so the constant search for food, is becoming less. So maybe what might be happening, now that you give this very important remark, is maybe they lose a bit of weight and their hormones start changing due to the weight change. So we had one No, we had 2 patients who had no gonadal activity, so they had no spontaneous menstrual cycle. And when they lost weight at their 38, 40 years, they started having a period, a spontaneous period. So that is what might be happening if people have weight changes, that these hormones are turned on, really.
I just think it's an area that I think there's more out there than we know yet. Yeah.
Thank you. Yes.
Thank you. I have 2, I think, quick questions. One regarding testosterone therapy. Is there an age where you would no longer consider starting testosterone therapy? We have a 21-year-old male who has not been on testosterone. We chose not to, both for concern about behavioral issues, but as well as the fact that we thought he was doing quite well. He's very lean, fairly physically active. So we chose not to in puberty. Is that something that we should be reconsidering?
Of course, I think that's always your own opinion, but I think it's very important to have them on testosterone, because it's not only for the bones or the muscles, but also the heart and the cardiovascular system. The heart and the blood vessels are really respondent to testosterone.
So you would do it long term, correct?
Yeah, long term. So we start at any age. So everybody who is not on testosterone, we start them. As I said, it's very important to start at extremely low dose, like 10% of what you would give normally. So when looking at the testosterone gel in non-PWS people, we give 50 milligrams. But in people with PWS, we start at 10 milligrams. So really low dose. Then we wait for a month, see what's happening, see if they get behavioral changes, see if they become hypersexual, because that sometimes happens if you give too high doses. And then when that goes well, we increase it with another 10 milligrams, which is still very low. So you really have to take for a year to build it up. But I would say it's independent of age, and we go on until the rest of their lives, because we also see that in non-PWS males, it's important to have the testosterone at good level forever. So if it declines, they really get complaints, not only of sexual complaints, but also of loss of energy, loss of physical activity. So I think, answering your question, I think you should start at any age, as long as you do it slowly, and go on forever.
Thank you. In regards to the growth hormone, what dose of growth hormone did you use in the study? And even though you're not looking for the growth hormone, the IGF deficiencies, do you use IGF levels to guide your dose?
IGF-1, we have done another study. We know that IGF-1 is not reliable in people with PWS, because the bioactivity of IGF-1 is lower. So they have IGF-1, but it doesn't activate the IGF-1 receptor where it would do that in non-PWS people. So actually we don't really look at IGF-1. We look at the DEXA, so the body composition, the muscle mass, to see if the growth hormone has the effect that it should have. So we start at 0.1 milligrams, which is very low dose. It's independent of weight. And we increase gradually per 2 weeks to 0.6 milligrams. And that's usually the dose that they have good response. Non-PWS adults usually have 0.3, so it's a bit higher than in the non-PWS adults.
Yes.
I just had a question about your research using growth hormone in adults. For the adults involved in your study, were they previously on growth hormone as children, or were they just getting their first dose of growth hormone as adults?
Good question. The majority has never had growth hormone. So they are really, let's say, the old school PWS adults as we know them. And we have some patients who had growth hormone as a child, but stopped for some reason, and then restarted it. The effects are less spectacular there, because they were already in a better shape. But the majority is growth hormone naive, as we call it, so they've never had growth hormone.
Can't see a microphone next to, oh, sorry.
Blue, yeah.
Thank you for documenting the growth hormone progress for individuals. It's been very important to us here in the United States because health insurance does give adults a problem with growth hormone continuation. That being said, my son is now 30, and I wonder how long they're going to let him stay on growth hormone and what your thoughts are on that.
Well, the situation between here and the Netherlands is, I think, really different. What I do if people are, what I did when it was not reimbursed for adults is I just shut my mouth. So I just kept on prescribing the dose that they had as a child, of course lowering it a bit, because that's what you do when they become adult, but not asking questions, and just as long as the pharmacy keeps giving it, it's okay. It's a bit illegal.
But do you think that given that growth hormone in a typical human being starts to decline at age 30, do you think that it's beneficial for PWS people to take it forever?
Well, I'm not sure whether the same system works in non-PWS people. So we do decrease the dose with age. So, of course, this is for the study. We start them all at 0.6. But if we see that everything goes well, we might go down to 0.4 or 0.3. So I would give it forever, as long as they do not develop sleep apnea. Of course, then you have to stop it or treat the sleep apnea. So as long as there are no contraindications, there are no reasons not to give it, I would keep on giving it. Because even for the elderly, the really elderly, it still works.
I think we've got time for one more question.
Okay, hi. I have a 22-year-old son who takes testosterone, and he gets, it's compounded, and I can't tell you what the dose is anymore, but we give 3 pumps on his shoulder. I just heard that there is an injection that he could get once a week. Have you experienced with that?
Yes, if I may recommend not to do it.
Okay.
Because what happens, the transdermal, so the patches or the gel, how do you say it? You do what nature does usually. So in non-PWS males, there is a peak in testosterone in the morning. And that's what you do with the gel. You give it in the morning, and then it's the natural way of, the natural rhythm of testosterone. What you do by giving these injections, if you give them a mega dose once a week, I see a lot of behavioral issues in the people using that, because before they get the injection, they're really tired, they have a lack of energy. And after the injection, they get very, like, sometimes aggressive or hyperactive or hypersexual, we also see, and they start, excuse me for the word, but they start masturbating in the middle of the room, for example. So we are very much fan of the gel, because that's where you prevent these problems from happening. And I know it's not, for many people, it's a bit strange to talk about this, but especially for people with intellectual disabilities, it's really important to have rules concerning sexual activity. That's what I wanted to say, because we see when it's not spoken about, we see some problems there. So we always discuss it during the consultation. So I would not use the injections. But that's my personal opinion.
No, I agree now.
Well, I'm afraid that we're really out of time now, and it really just remains for me to thank you, Laura, for sharing your experience. I think we've been treated to some real expertise and insights, so thank you for that.